Today we have a special guest, Dr. Stephanie Seaton, and she's a board orthopedic surgeon practicing in Dallas area for many years. And a couple of things that I came to know, which I didn't know before I know her, that she used to do a hurdle running, right?
Yes, I was a hurdler.
Hurdle, yep. And also I found out that she holds many records in 400 meters, 100 meters, and you also co-founded the track and field team
At Duke University.
in Duke University. So she has a lot of experience in playing in the sports herself, and right now she has been seeing a lot of patients with the sports injuries and also common surgeries like joint replacement, rotator cuff surgery, any joint surgery basically, right?
Correct.
So thank you so much for coming.
Thank you.
A lot of patients had a lot of questions about their injuries and joint, like pain, aches and pains in the joint. So we're gonna try to get some answers, some common questions that we didn't ask by the patients. So just tell me about a little bit about yourself, what on daily basis, what kind of patient or population you see right now?
So I see all kinds of joint injuries. Could be soft tissue, could be bony, so it goes the gamut from fractures all the way down to just my shoulder hurts, my knee hurts, and you don't have a trauma that caused it. Probably the most common thing that I see is going to be knee pain, whether it be just knee pain from overuse or knee pain from arthritis. That's probably the most common complaint that I get in the office. Probably the second most common is going to be shoulder pain.
Okay.
And that also could be related to overuse, or it could be I fell or I lifted something too heavy and they might have a more severe injury.
Okay.
But just pain in general, probably arthritis of the knee is probably the most common thing that I see.
And we hear this a lot, and many people don't have any idea, what to do. Like when they have a pain, they don't, first they go on Google or
Right.
YouTube, they try something, didn't work, and then they got to the point where they cannot bear any pain or it's interfering with their daily life, then they try to take some actions. So what do you think, at what point they need to see you, or what are the basic stages? We're talking about with the orthopedic, there are big field. You can get accident injuries, or sports injuries, or any kind of pathology, congenital, not congenital, but any kind of genetic disorders, something like that. But let's talk about more osteoarthritis or rheumatoid arthritis.
So first I want to get a definition of what arthritis is, because I get asked that a lot.
Okay.
I have some patients who come in and their primary doctor has told them, oh, you have knee pain, it's arthritis.
That's true.
And they don't base it on anything. Or I have patients that I tell them they have arthritis, but what is that? What does that mean? They get scared.
Exactly. Yeah.
So true arthritis means you've worn away the protective coating of a joint surface. So every joint is bone and it's covered with a rubberized coating. When that wears away, that's arthritis.
Okay.
Now there are different degrees of arthritis. Arthritis can be just a softening of that rubber coating, or it can be completely worn down the bone, which is the last stage of arthritis.
Like bone.
Arthritis by itself, though, doesn't necessarily hurt. So if you have pain, it doesn't mean you have an arthritic joint.
Yep.
It could be a variety of different things. Now, once you come in and we get an x-ray, that's usually the best way to tell, even more so than an MRI. A lot of people want an MRI to diagnose arthritis, but you can usually tell that from an x-ray and your exam. And once the x-ray starts showing changes, maybe the joint gets narrower because now that coating is not keeping it apart anymore, or you might develop spurs. Spurs are overgrowth of bone because there's abnormal pressure on the surfaces that the body reacts by forming these little outpouchings, or we call them spurs.
Yeah.
The technical term is osteophytes.
Osteophytes.
When those form, you might feel bumps or lumps on the joint. By themselves, they don't hurt. It's the rubbing of the surfaces together that potentially can cause
That can cause some sharp pain.
Right.
When they're walking. So when someone like that, comes with the osteoarthritis or having some friction between the joint, or that cartilage is worn out. Because I know, I told many patients that at certain age, everybody will have some kind of wear and tear.
Right.
But as long as it's not bothering you, as long as it's not to the extent, you're still okay. You can just do some exercise and you can prevent it. So at what stage do you recommend it that, okay, this is something severe, like what kind of damage you're looking at to warrant the surgery?
So surgery for arthritis is usually the last thing that we recommend. So we initially treat based on your symptoms.
Okay.
So if it's pain, we try to find out what's the source of the pain. Is it painful because the knee is swollen? Sometimes an arthritic joint can rub together and it causes fluid to build up. And that fluid stretches the lining, it stretches the nerves, and that's where the pain is coming from. So we try to treat the fluid, which might be medication and anti-inflammatory, or it might be draining it. A lot of those things can be done prior to getting to the point of surgery.
Okay.
If the patient is overweight, sometimes that extra pressure on the joint causes pain, and finding ways to lose weight. Now, a lot of people will say, well, I can't exercise, so I can't lose weight. But there are other ways to lose weight other than exercise. Exercise is a way of toning the joint, but watching your diet and changing your activities or the way that you eat and when you eat and what you eat, all of those things can help start your metabolism increasing so that you can lose weight. Then once the pain, and then we do other modalities to try to control the pain, and then you eventually would be able to exercise again. Other joints is going to be different. In the upper extremity, it's a little easier to start exercising because it's not a weight-bearing area.
Exactly.
But you can still have pain, so modifying activities, it might be if you have pain only when you lift overhead, we may have you avoid lifting overhead for a while. If you're an athlete and it hurts only when you throw, we'll have you rest from throwing. Or if you're playing tennis and it hurts a certain way, we may have you modify your racket or the way that you do your backhand so that you don't get that pain.
And that's what we do a lot, because when someone comes here, the first thing we do, like as a physical therapist, is watch their movement. Like what movement they're having issue. And if they have some issues with certain movement, we modify.
Right.
And then we can tell them, there are 1,000 ways of doing exercise. So there is not only one way. If one way is hurting, we can always modify. There are different types of exercise, different modes of exercise, so we can always help them to do that.
And those things are important because I can do other things to help with the pain, but if you're doing the same wrong technique that started it in the first place, it'll come right back.
Exactly. Yeah, that's true. You have to go in the root cause, like what is causing that problem. Because you brought a really good point about the arthritis, because I would say 90% of the population that I see when I see for the knee arthritis, they believe that their life is done, like nothing can be done after that. Like the ultimate option, they're leading towards the knee replacement only. And I tell them, okay, like that is definitely a possibility, but it depends on your situation. Like what stage you are, how active you are, what is your lifestyle. There are so many factors, like what you like. I have a lot of patients who does a lot of wrong technique when they're doing exercising, which cause more pressure on the knees, like squats, like in the gym. Like when you do the wrong squats, that can put a lot of pressure on the knee, So there are so many factors behind it. What about the steroid? Like, when do you think, person is appropriate for steroid, especially with the knee pain, especially with the arthritis?
I usually tell my patients I have a continuum of treatment starting from one end to the far end, depending on what their symptoms are. Okay. So when they first present with the pain, I'm going to start at one end. It might be changing their diet. It might be modifying their activity. It might be physical therapy and exercise. Sometimes there are different taping techniques that might alleviate the pain. Sometimes strengthening of certain muscles can alleviate pain. I might start them on an anti-inflammatory medication to help with pain. Herbal supplements like glucosamine and chondroitin sulfate and turmeric are things that naturally can decrease inflammation and pain. So I'll usually start there. When they try those things and they say, you know what, I did it, it didn't quite get rid of my pain, I'm still having loss of function because of the pain, that's when we look at steroids. Steroids are short-term relief, typically about 3 months you're going to get relief. And so they're not a cure. And a lot of people will say, well, aren't I just tricking my body? Well, sometimes the patients can't exercise because it hurts. And we use the steroid to calm the pain so that they can exercise.
Exactly.
Then the steroid wears off, but they're exercising, and that's what keeps it. So I've had patients say, oh, that steroid injection lasted a year. Well, it didn't, but the exercise kept the pain away for a year.
Exactly.
So we use it as an adjunct to try to get people to do other things to keep their pain from coming back.
And then they say, many times, because people think that steroid is gonna cure the problem.
Right, it's not a
And
cure.
like I hear so many times, like a year ago I had a steroid and my knee was fine, absolutely fine. And then I was doing everything fine, but again it got it back. So and then the second time I got the steroid, it didn't last it that long.
Right.
Why? I said, okay, that just, see, when you have a steroid, that's the perfect time to work out. Because your pain is down, you build up the strength.
Right.
You know, then you're not gonna have any problem in the future. So yeah, so definitely like, you know, that's just one like aid towards the treatment plan.
Right.
So that brings me one more question that I've been asked a lot lately is PRP.
Mm-hmm.
Because many people ask like, okay, what about PRP? Can I do the PRP? Is gonna regrow my cartilage with the PRP?
Right.
Is it a permanent solution? Like if I do PRP, I don't need to do knee replacement, or like I'm not going towards that. So what are your thoughts on PRP?
So the answer to that is no and no.
Okay.
PRP stands for platelet-rich plasma. Basically, it's a component of the blood. We take the red blood cells, and part of the red blood cell is made up of platelets, and we take out the platelet-rich part of it, and it's very high in growth factors. Those growth factors act as a natural anti-inflammatory. So when they're injected into an arthritic joint, and this is something we're learning about, but it's been shown more consistently recently, in an arthritic joint, it decreases the inflammation. It does not put cartilage back. If you've got big potholes in your knee because the cartilage has worn down, it will not fill those potholes.
Fix that.
But it may decrease the inflammation of an overall inflamed joint for up to about 9 months to a year.
Okay.
Eventually it wears out of the joint and symptoms will come back. So it's not a permanent change.
So we can say in technical word, not technical word, but like it's a little bit next stage than the steroid.
Yes. The difference is, number one, steroids are anti-inflammatories, so just like taking pills, except it's a very concentrated
To the localized area.
directly into the joint. But because it dries it decreases the inflammation by constricting red blood cells, it also potentially can dry the cartilage. If you dry the cartilage, it may crack and peel and eventually can get worse, which is why when patients come in and they say, oh, I felt great, it didn't hurt at all, but it only lasted 2 weeks, can you give me another one? You start stacking up steroid injections, you can actually make the arthritis occur worse and more rapidly. So that's why we try to space those out. I don't recommend doing a steroid injection more than 3 or 4 times in a year to give it enough time to get out of the system. With the PRP, we typically would repeat those maybe once a year because it can last longer. And the earlier that you try the injection, the earlier in the stage, the better your result is going to be. For example, if you've got a patient that has very minor arthritic change and another patient that's got bone on bone and the joint has changed shape and the knee is completely destroyed, PRP is not going to help that joint, but it will help the one with the mild inflammation. So it is something that you can consider fairly early on in the course of arthritis. Sometimes we'll use both. The person may try the steroid first just to see if they're going to get any result because a steroid is much more inexpensive to give. And then if they're looking for more lasting relief, then they try the PRP. I get more requests for PRP from my athletes because they're looking for more natural things in their body, and that's a very, very reasonable thing to do. And it can keep them going, it can keep them on the court for a long time.
And then they can get back to the training and build up all the strength and everything. So so let's, like, as we talk about the athletic people, so let's change it a little bit here to the ligament injury. We see a lot of, like, especially like rotator cuff injury or meniscus tear or like ACL, PCL, like, tear. So one of the common things that I've been asked by younger population, especially the meniscus, like they torn some meniscus during the sports activity or even the older age, like 50 plus. I have few patients who just fell down outside and they twisted the knee and they torn partial torn ligament or meniscus. So what are your suggestions, when they should need see the ortho? Like typically if it's a partial tear or it's just a strain or something, with the proper exercise and everything we can definitely help them. But what do you think, what stage do you think they need to see the ortho?
So first of all, the meniscus is a small disc that's inside the knee. There are 2 of them. They act as a shock absorber. So when you walk and put pressure on your leg, it's almost like a shock absorber in a car. It takes
just,
that
yeah,
pressure
take it, yep.
and alleviates the contact of the two bones together, the femur and the tibia. When that gets torn, you lose some of that shock and there's more force between
On
the
the
bones.
bones.
So depending on the type of tear is going to determine what symptoms you're going to have. A very minor partial tear may cause a little bit of pain, but you can walk on it, you can exercise, eventually the symptoms get better. Those typically I don't see in the office because the patient gets better. So you can have a small or a partial tear of your meniscus and you can live with it. Nothing needs to be done with it.
Okay.
When that tear is a complete tear, it goes all the way through, or especially in a young person, if it goes through and pushes out of place, it displaces, you're going to have more symptoms. Usually the knee will swell.
Yep.
You will get catching. You might even get locking.
Catching. Yep.
Those are symptoms that are more serious, and a lot of times those need surgery because we want to try to catch it while it can still be fixed, while it can still be repaired.
Okay.
The meniscus has parts of it have very low blood supply and parts of it have very good blood supply. So the area high in blood supply, we want to save that if at all possible because you need that tissue for absorbing the shock. When you don't have that, either because it's torn completely or it gets removed with surgery, those are the people that end up developing arthritis at a younger age because there's no longer anything to keep
shock
it apart.
absorbing.
Right, right. So if you have a knee injury, say you squat and you feel a pop and then the knee swells up, that's something we want to see right away.
Yeah.
If it locks and you can't straighten the knee out and you're trying, that would be something we'd want to see right away.
Right away. Yep.
Yeah. Just having some pain, but you can walk it off, and I would probably have you try pain medication, anti-inflammatories, maybe a knee brace or a wrap. Try that for a few days first, and then if you're not feeling better, then you would see that patient.
So what are the chances in a younger population, let's say they did the partial tear, meniscus injured during the play or something like that, what are the chances, what are the outcomes in the long term? Like, are they more prone to get more arthritis over the time, or what are the tips to prevent future complications?
So first of all, there's no way to prevent arthritis per se. Some people can do everything right and they get arthritis because it runs in their family. Or you may have had an old injury and didn't recognize it, and that can lead to it. So we try to keep the joint as healthy as possible by keeping it mobile, keeping it moving, keeping the muscle strong around it. That's the best way to keep it from getting worse. But sometimes you do everything and it does get worse. Partial tears typically don't need surgery. In young people, a lot of times they can heal spontaneously. So it's something that we watch and we base it on your symptoms. Just because someone comes in with an MRI that says I have a partial tear, that by itself doesn't mean they need surgery. Even a complete tear, as you get older, we're finding surgery doesn't necessarily make you better. So I get a lot of patients who come in and they're in their 50s, 60s, and they've got an MRI that shows meniscus tear. But it also shows they've got no cartilage in that part of the joint, or the meniscus might be pushed outside the joint, and they want a scope because they were told they had a meniscus tear. But the fact is, at that point, the arthritis is probably causing more of the pain than the meniscus. And if I go in and just treat the meniscus, odds are that arthritis is going to get even worse, and then they'll end up needing a major surgery more quickly than they would otherwise need. So we try to control those symptoms with injections and medications and physical therapy, and try to buy time until they're ready for that bigger surgery.
What about the ACL and PCL? Like, those are the common injuries, mostly in the sports injuries, like when they're playing, So more on the recovery side. Let's say you did the surgery, if someone torn, total rupture of the ACL, and you did the surgery. What are the chances? How soon they can get back to the sports? Because I've been every time they come, especially with the younger population, they wanted to push. And we typically have to follow the protocol, because right away you don't want to just start doing all this aggressive exercise. So what are the realistic outcome of the ACL repair?
So realistically, I try to counsel my patients. I get the same thing. They miss their sport, especially the very young patients. But the reality of it is, it's about a year recovery. Not that you couldn't do it if you tried,
that's
but
true,
there's
yeah.
a significantly higher risk that you're going to re-injure it.
Yeah.
And we do see ACLs, they have an artificial graft now in there, and it tears again when they go back to the sport.
Too early.
So depending on the sport. Now, I do have some athletes, maybe they tore it doing something other than their sport. Maybe they were playing on a trampoline, but they normally play basketball. It's a little different.
Yeah.
But for being able to plant and pivot and twist, we usually don't even let them try that until at least 6 months after the surgery. One of the reasons the thigh muscle, the quad, gets significantly weak, and it can take at least a year to build up the strength till it's equivalent to the other side.
Exactly.
Sometimes even longer than that.
Yeah.
So when you're running, when you're changing direction, it's not symmetric, and you're more likely for the knee to buckle again because you don't have the same strength that you do on the other side. So we do a lot of work on trying to balance the strength and the muscle girth to get them to be even. But pivoting and cutting sports, soccer, football, basketball, volleyball is another one. All of them involve sudden changes in position. We usually don't, they're out for that year and possibly can go back the next season.
And that's true, because many times when we see even the younger population, when you see the patients after surgery, there are lots of muscle vesting. When you compare with the normal side, the volume is way less than the normal side, and then it takes longer to build up.
Yes.
You know?
Yes.
So I tell them, be patient, you just have to keep on working. I always give the example that, okay, you know what? Let's say you're doing the bicep curl, and after you're doing once or twice a week, and then 2-3 weeks you said, I don't see the shape. You don't. It takes time.
Yes, that's
the
right.
commitment and consistency is to be there to see the results. So for younger population, definitely that take your time. Don't rush too early, because I have seen some patients that push too hard too early, and they end up with more problems.
Yeah.
You know.
We usually let them. They're lifting weights the whole time. I mean, we even guide how they're lifting weights, whether they can lift away from their body versus toward their body. When they can start doing leg extensions, that's usually months down the road. The ACL has to grow into your bone before you can start doing that strength training. Or you'll just stretch it out and it'll end up being loose. I usually have patients wait till about 4 months after the surgery before they start jogging, because it takes that long when they can leap and land with their full body weight and control that knee. And so usually they're excited to be able to run, but we're talking straight ahead, not pivoting and cutting. Pivoting and cutting usually is somewhere around 8 months, and then we're building up strength at that point. Also, some patients will, depending on the sport, will have them wear a brace for the first year of play. It will not stop you from getting an ACL tear again, but it helps to stabilize the joint when you are in
I think proper training and the coach also plays a big role, that how they're preparing before they play, warm-up exercise, cool-down exercise. There are so many more factors into than just getting back to sports. So,
and especially in girls, we find that a lot of the women's sports don't have the same training that the men do, the same conditioning that the men do, and they're more prone to getting ACL injuries in the first place. So it's very important, especially after an injury for them, that the conditioning and the repetitive things to build up so that they're less likely to get it again. Making sure their hamstrings are balanced with their quads, because when they're not and one pulls more than the other, that's when it's more likely to shift that joint.
Yeah, the quads and the hamstring, they has to be balanced. Yeah. So let's a little bit at the end we're going to talk a little bit about shoulder.
Okay.
So what kind of more common, because every time when someone has a shoulder pain, they just blame rotator cuff, which many cases true. Rotator cuff are more prone to get injured or torn. But what are the most common cases you see in the shoulder pain?
So probably more frequently we'll see what we call impingement, which basically means the rotator cuff gets pinched when you reach your arm up overhead, especially if you're doing it repetitively. I'll see someone who was working in their garage and was painting, and they were like this for hours, and then all of a sudden they can't lift their shoulder. That is the rotator cuff, but it's not a tear. It's inflammation of that bursa, or the space above the rotator cuff, that causes pain. So I see that probably most commonly.
Mm-hmm.
The rotator cuff is what does lifting and rotation, so anything that's repeated over and over again can aggravate that.
So basically we can say it's more like stages, like it starts with the impingement. If you ignore it, the pain, and keep on doing the things that you're not supposed to do, that impingement can turn in the inflammation of the tendon,
Yes.
becomes tendinitis, tendinopathy, you ignore that, build up the scar, become tendinopathy, and even after that can lead to frozen shoulder, but not every shoulder pain is frozen shoulder.
Now, frozen shoulder is a little different entity. They're different causes because that doesn't necessarily start with tendinitis. That comes on like that.
Yeah.
And so there are other factors such as diabetes or
Yeah.
hypothyroidism that make you more prone to it, but the majority of people didn't do anything, just started in the blue. So that's kind of a separate category
Yeah.
from the
From the
tendinitis,
stage, yeah.
tendinopathy. The tendinitis, tendinopathy more so can lead to the atraumatic tears.
Yeah.
Someone who develops a tear, a hole in the rotator cuff, and they say, well, I didn't do anything, I don't know, or like for instance, swatted a fly and it tears easily. Usually that tendon wasn't normal to begin with.
Yeah, exactly.
And so it can tear more easily.
Yeah.
As opposed to the traumatic, someone who falls off a ladder and puts their arm out and
You pull
tear it
the
that way.
tear it,
So
yeah.
there's a reason. It was a normal, healthy tendon, but it's just the force was so strong it put it off the bone. So I see all those different entities that can all cause pain. Most of the time, if it's something traumatic and it's pulled completely off the pain, we're usually more quick to go to surgery. Again, we look at other factors. If it's an 85-year-old that fell and rotated and tore their tendon, probably wouldn't go straight to surgery in that person. I might not ever go to surgery because their needs are less than the 45-year-old who did the same thing. But therapy is always a big part, even more so in shoulders than the knees, because no matter what I do, if you don't move the shoulder, if you don't build up the strength, it's not going to get better. The pain will come back. Even if I inject it, it'll feel great for a while, that will come back.
Yeah.
So it's very important, especially with frozen shoulder, which is where the whole lining of the joint gets tight and it's inflamed and it's hard to move it because of pain. I can do things to temporarily control that pain, but if you don't move it,
you're not gonna improve it.
you go right back to where you started. So.
Yeah. What about the partial tear? Let's say if someone has a partial tear, what are the outcomes? Like, what exactly, if someone comes with a partial tear, with the pain and symptoms and everything, what is the best remedy? What are the things that they need to do immediately?
So partial tears, there are things that we look at. How big of a partial tear is it? If it's more than half the tendon, the studies show that within 2 years it will probably tear the rest of the way through and become a full thickness tear. Tears that are less than 50%, which we can tell based on an MRI, those sometimes will stay stagnant. They don't heal. The part that tears is where they attach to bone, and that's where the lowest blood supply is. So once it tears there, it doesn't heal itself. The muscle is pulling it away from the bone, so it can't put itself back on the bone. But smaller partial tears can be tolerated without surgery most of the time. And then we also look at where is the partial tear. Is it on the top by the bursa, or is it in the joint on the underside? The joint side tend to be less tolerated without surgery than the bursal side. So treatment might entail anti-inflammatories, steroid injections in the area where the partial tear is, and exercise, strengthening, building up the rotator cuff, building up the muscles around the deltoid, the trapezius, working on what we call eccentric exercises, back and forth, throwing a ball and catching and pushing, uses different muscles than just straight lifting. Those are all things that we look at with partial tears. And a lot of people have partial tears and they do just fine without surgery.
Many of my patients, like when they come with a partial tear with proper, like my goal is to educate them first. Like the things that may increase the chances of injury, I tell them, okay, how to prevent it or how to modify it. Because with the proper exercise and proper, for example, impingement that you were talking about, many times their posture is like upper back is like rolled shoulder. Every time you're gonna do overhead movement, there are chances of impingement. So I start with the basic like postural education, or like their occupation required that kind of movement, so I go over that one. And proper eccentric exercise and proper mobilization. I see partial or less tear tend to show better results with therapy. If someone with the full tear, definitely they're having a lot of trouble. So I tell them, okay, if you have a full tear or you can't even move your joint, definitely you need to see the ortho for sure.
Right.
But what are the let's say if they've gone through the surgery, like if it's a rotator cuff tear and you repair it, what are the outcomes? Like what exactly, like what is the time frame they're looking at for the normal activities?
So it depends on the size of the tear. The bigger the tear, the longer it's going to take to heal. But I always tell my patients expect a year. And people hate to hear that, and you're not hurting the same for that whole year, but it's a very long recovery because it takes 10 to 12 weeks just for that tendon we reattach to bone to actually adhere to the bone.
Yeah.
So you can't really start weight training for 2.5 to 3
Exactly.
months.
Yeah.
The first part of the therapy is just working on stretching and getting your range of motion right. And then once you start lifting and doing resistance, you're only doing small muscles, small weights initially, and then building back up. So to be able to reach overhead to change a light bulb easily could take 6 months.
Yeah.
To be able to throw a ball is probably going to take a year.
Yeah.
And the bigger the tear, the less likely those things are going to happen quickly. And there are chances some repairs that we do don't heal. So we teach that patient how to function within their everyday activities, knowing that, they probably won't have the strength with reaching overhead, but they don't have pain.
Okay.
So the surgery is much more predictive at helping pain than it is for getting strength back. And so we try to educate patients about that. We're trying to control your complaints so that you can do your activities of daily living.
Yeah.
And then if you get strength on top of that, that's a bonus.
Yep.
So we try to deal with it.
The
that
stages
way.
wise. Yep.
Exactly.
All right. So thank you so much. At the last, tell me what is the advice you have for the people who has arthritis? They're having some minor aches and pains, but they don't want to do surgery because always they're in a fear. Like anytime I have arthritis, I have pain in my knee, or I have to go to the knee replacement. So what are the tips? What are the things that they can do?
The key thing is, I love to operate, but it's the last thing that I want to do for the patient. I want to get them as good as possible so that that's our last choice. So I always put that on the back burner so that their fears are calm. If you can look at your activities that you're doing. Most people that come to me and they have knee pain, they're at least 50 pounds overweight and they're not active at all. They go to work, they go home. They don't even walk their pets most of the time. So finding some way to get moving, getting active, whether it be walk the dog every day, whether it be take your husband and go out for a walk after dinner every night. I don't recommend dieting. I recommend making a lifestyle change with your eating habits. So that might be drinking more water, eating more fruits and vegetables, making vegetables the bigger part of your plate, and the starches and the meats the small part of the plate. Making big changes to your diet, you can't keep that up.
Exactly.
And the people who make the smaller changes, those are the ones who actually
make the life changes. Just don't do for 1 or 2 months.
Right.
I always tell my patient, like, think about this. Whatever change you make, think that can you make these changes the rest of your life?
Right.
If the answer is yes, do it.
And involving other family members makes a difference because it's hard to do it by yourself, especially when other people in your household are eating, the way you're used to eating. And so making it a project that you all can do together will help everybody. So that's the way I recommend starting. As far as your joints, the movement is what is going to help. And I don't mean go out and walk 5 miles. You might even only be able to walk a short mile. Okay, start with walking 15 minutes. If you have access to a pool, getting in the water and doing jumping jacks or running in place, you won't have pain when you're in the water.
Exactly.
Get it moving. Stationary bike is another thing that you can have terrible arthritis, but you can get on a bike with low resistance and you can build up your heart rate. So those are things that are going to help your overall bring muscle flow bring blood flow to the muscles so that you're strengthening around that joint, and you'll find with time you'll have less pain. It does not happen overnight. A lot of people say, "Well, I tried that." Well, how many times did you try it? Twice. No, that's not going to work.
You gotta try months. Before you see the results.
That's the best way.
So I think, the best way you can say, like, the healthy habits and losing weight are the number one thing that can really help them.
That doesn't matter what yourself.
Exactly. It doesn't matter what direction you're going, but this will help you regardless.
Right.
Yep. What about the shoulder pain? Like, if someone has a like lots of injuries already, like having a lot of issues with the shoulder pain, what is the best advice you can tell them?
One of the big things I can tell you for women
Mhm.
is check your purses. So many of them come in with shoulder pain and they carry a purse that weighs 15 pounds and they lug that thing and they lift and they pull and they reach in the back seat of the car and pull.
Yeah.
I tell them to get a small purse
Mhm.
and put only what you need for that particular afternoon. And if you need something more, have a second bag in your, somewhere else. Because that is an easy thing to change, and they consistently aggravate their shoulders by lifting. We see that all the time.
And they, it does affect the posture too, because if you're just hanging on one side with that much
it
weight,
makes you lean over.
you may end up with more back pain and neck pain too,
Yeah.
So,
And I think regular stretching is another thing.
Yes.
When you get up in the morning or get out of the shower,
Yes.
stretching the arms overhead, moving the neck back and forth, stretching the arms across the body. Those are things that just keep the joint limber. And so that when you are going to lift up, the coffee table to move it over, now you're more conditioned to be able to do it. Try to lift, proper lifting techniques, hold things closer to your body. If it feels too heavy, get someone else to help you. Those are ways to help prevent injury.
Okay, wonderful. So thank you so much for answering. There are lots of good answers, that people will appreciate that for, because many, as I said, we hear that questions on day-to-day basis. So whoever is watching videos, and I hope we answer many of your questions. If someone wants to reach out to you, how they can reach out?
The best way is to reach me at my office. I work at Texas Bone and Joint. The office number is 877-314-8990. I'm in the Las Colinas and Castle Hills locations, but we have other locations, multiple doctors at all of the locations.
Okay. All right. Thank you so much for
You're
coming.
welcome.
Okay. Thank
All
you.
right. Thank you.